refresher today. And you have a homework assignment on epidemiology. We'll have just one homework for the internship. It's already uploaded. And it's mostly on epidemiological studies, types of studies, the designs of epidemiological studies. Most of the topics, the questions during the final exam, the state certification exam, will be also on epidemiological studies, so we'll pay most attention to this today. But let's have first a brief introduction to basic epidemiology again. So some historical backgrounds, ideas about epidemiology and hygiene appeared in ancient Greece. Probably they existed even before, because Greek medicine is a descendant of Egyptian medicine, and then it was transferred from Greece to Rome, from Rome to the Arabs, etc., until finally coming to modern-day Western medicine. And so out of the different works attributed to Hippocrates, of course, most of them are not written by Hippocrates himself. And so out of them, several are dedicated to epidemiology and hygiene. So these are the roots of public health. And here's a famous quotation from Hippocrates translated into English. Apparently, it's on the importance of social determinants, factors on the health of a group of people. So let's continue then. After establishing that epidemiology and hygiene existed in one form or another, even in ancient times, the population pattern of disease is not solely dependent on the characteristics of individuals, but also on the interaction between individuals with each other and the environment in which they live. This is a very basic understanding of epidemiology. An example, the protection given to children who are not immunized against measles by the immunization of other children in society is a phenomenon known as herd immunity. So, in general, of course, herd immunity happens when enough of the susceptible population, susceptible to a certain infectious agent, is immunized one way or another, either through having the disease or through introducing a vaccination. Of course, the coverage needed is different according to the disease. If it's some very contagious infection like measles, then the necessary coverage has to be very high, like more than 80% or 85% of all susceptible children should be immunized one way or another. Herd immunity happens sometimes in peculiar circumstances because some of the live vaccines used in epidemiology, in fact, confer immunity to other unsuspecting children who their parents maybe did not want immunized. That's because, of course, the vaccine strains there are still able to replicate and to infect other individuals, even though they are incapable of causing the disease. In most cases, of course. If you remember, in the case of poliomyelitis, two competing vaccines were used in the past, the vaccines of Sabin and Salk. And one of them is, of course, whole body killed vaccine, and it's safe. The other is not so safe because sometimes this vaccine strain can start to behave like a true wild poliovirus and in fact cause the disease. The one that is live and administered through the mouth. Okay, so the individual and the population. These are some basic explanations on the pattern of disease, which you can read at home patiently. There's no hurry. I'm going to skip most of these things and focus on some explanations, in fact, because you need to understand the underlying logic of basic epidemiology and the epidemiologic studies, because learning by heart is difficult. You'd better, of course, understand things. So, how to define epidemiology? Apparently, the term comes from three Greek words. Effectively means something like study upon populations, study on the whole population. So it sounds a lot like demography, by the way. So the definition is in fact a bit incomplete, because epidemiology does not simply study human populations. It in fact studies the spread of diseases among human populations and also the spread of factors influencing susceptibility to these diseases. So this is the definition in John Most's Dictionary of Epidemiology, which we're supposed to work with nowadays. If asked to provide a definition on epidemiology, you should provide something like this. Do not try, of course, to memorize it literally, to know it by heart, but be prepared to explain this definition. So epidemiology is the study of the distribution and determinants of health-related states or events in specified populations and the application of this study to control of health problems. So epidemiology apparently studies the spread of diseases among human populations, the spread of factors contributing to the susceptibility to these diseases, their spread, and finally how this knowledge is used to solve public health problems. Central paradigm of epidemiology. Epidemiology is the science and practice which describes and explains disease patterns in populations, puts this knowledge to use to prevent and control disease and improve health. So The central paradigm is that patterns of disease in populations may be analyzed systematically to provide understanding of the causes and subsequent control of diseases. Some modern definitions state that epidemiology is the study of mass events in medicine, or that epidemiology provides intelligence for the health services. Of course, these are all true as well. As for the so-called pattern of disease, well, in general, in very general terms, the pattern of disease for communicable diseases, so for infectious and parasitic diseases, which of course you study as a separate discipline, you study separately the epidemiology of infectious diseases. Though, of course, during the state exam, we'll gather together with the other commission, and then you have a combined grade from social medicine, infectious epidemiology, infectious diseases, and IG. So the pattern of disease in infectious diseases is basically the so-called chain of infection. You have a linear transmission, cause and effect. You have the source of the infection. You have a certain infectious agent causing a certain disease. You have the mechanism of transmission happening in a certain environment. And finally, you have the host, the susceptible organism. So, for example, the source of infection is an infected body of water, like a lake, river, whatever. And there you have a certain infectious agent, like, for example, cholera, Vibrio cholerae, or abdominal typhus, Salmonella typhi. What is then? Now you have the source of infection, infected water. You have in a certain natural reservoir, for example. Now, in the case, of course, of Legionellosis, Legionnaire's disease, it won't be a natural reservoir of water. Then you have the infectious agent, like Salmonella typhi. Then you have the mechanism of transmission. It's a waterborne infection. And finally, you have the host, the susceptible organism. And there is universal susceptibility here. Now, for example, you have malaria. So you have, for example, an infected individual, a carrier. He's bitten by a mosquito from the genus Anopheles, and this insect is called the vector here, living transmitter. But you can also have, of course, vomits in vehicles in epidemiology, not just living transmitters. And apparently it's a transmissive infection. So it transmits through bodily fluids. And then a mosquito bites another human, and his blood is also infected by the Plasmodium falciparum. So there you have it, the whole chain of infection. Now, things are, of course, pretty simple and straightforward in infectious epidemiology, because there is one agent and one disease. It's easy to diagnose the epidemic. It normally happens pretty fast. And then you have to break the chain of infection in its weakest link, which is normally, of course, the mode of transmission. Normally, this is what's addressed, the only exception being apparently airborne infections, where it's not the mechanism of transmission that is addressed, but the host link. We are trying to achieve herd immunity there. But as you probably remember, things are not so simple with non-infectious diseases, unfortunately. The pattern of disease there is described as the constellation of risk factors. So you have a certain disease, and then you have an awful lot of risk factors associated with the disease. So we don't say causing the disease, we say associated with the disease, which means that the presence of each of these risk factors in the environment of the patient raises the probability of the disease happening, of the disease unlocking. Now, some of these risk factors, of course, may be strongly associated with the disease, so they can cause it without the presence of other risk factors by themselves, and then we have the causal relationship, and we can safely say that this causes this. Like, for example, tobacco smoking, we can safely state causes lung cancer or laryngeal cancer, squamous cell carcinoma, and for example, that alcohol abuse causes liver cirrhosis. In most cases, we do not claim this. It's in fact the interplay of many risk factors, which in the end, so behavioral risk factors, genetic, metabolic, occupational, environmental risk factors that in the end cause the disease. So things are not that easy with non-infectious diseases. It's hard to put such epidemics under control. If you have an epidemic of malaria in the country, or even tuberculosis, you can you can put it under control. But if you have an epidemic of diabetes type 2 or metabolic syndrome in the country, it's not that simple to put it under control. It may take decades and generations to put it under control. But of course, still we have to try. And there are so many risk factors associated with non-infectious diseases. Probably the record holder is coronary heart disease, where more than 100 risk factors have been identified. And apparently, all of them should be addressed. So, sorry, just a 5 minutes break. I have to take a call, and then we'll continue.
Okay, Professor.
Okay, let's continue now. So, applications of epidemiology in general. It can be used, of course, to control diseases. Probably this is the most important task of epidemiology, to identify and stop epidemics, be they infectious or non-infectious epidemics. So that is, stop diseases that take mass spread and affect large groups of people simultaneously. And so the task of epidemiology is a little different from the task of, let's say, infectious diseases, even though they are closely related. But infectious diseases, of course, is a clinical specialty that focuses on the diagnosis and the diagnostics and treatment of an individual patient, while the task of epidemiology is primarily to protect those who are yet healthy. Of course, this brings even more benefits to society as a whole. So, apart from controlling diseases that can take epidemic spread, epidemiology is used to understand the causes of diseases. Now, it's not that epidemiology is often used to understand the causes of infectious diseases, because in most cases, causes there are well known. You must have some new disease, completely new disease emerging for epidemiology to step in and try to establish the agent. Like the Legionnaire's disease, when it first appeared, was a completely new disease, or the HIV/AIDS, the acquired immunodeficiency syndrome. It's not that it was really, by the way, a new disease, because it had existed in Africa for quite some time before that, but it became known to the world after being imported to San Francisco. And you know that during our 21st century, several new coronavirus infections appeared. Apparently, the SARS appeared first, followed by the MERS, and COVID-19 came third. And yes, these were completely new diseases for us. But it rarely happens that new diseases appear. Once every 10 years at least, a new infectious disease appears. But understanding the causes of diseases, this mostly applies to non-infectious diseases, because their epidemiology has to identify all the possible risk factors contributing to a disease, and then try to test the strength of association. So, by what percentage is the probability, or how many times is the probability of the disease happening increased if a certain risk factor is present in the environment? It's not so easy there to establish what is a risk factor and what is not in non-infectious epidemiology. So for this purpose, large epidemiologic studies are undertaken. So epidemiologic studies on thousands of people normally are undertaken mostly for this purpose, to understand the causes of non-infectious diseases. Epidemiology has other uses as well. For example, it's used to study the natural history of disease in individual patients. It is used, of course, to test the efficacy of new vaccines, drugs, surgical procedures, diagnostic tests, etc. That's why we have clinical epidemiology and evidence-based medicine nowadays. Okay, let's continue now. Let's click this. Let's keep this. This is the so-called triad of epidemiology, which is again a central concept of epidemiology. You must know it is the normal variation of a disease by time, place, and person. If you take, for example, common flu, you easily notice that this is a disease that always takes epidemic spread. It is either caused by a human influenza virus of group A or group B, one of the many possibilities there. Or it is sometimes caused by a parainfluenza virus, rhinovirus, adenovirus, respiratory syncytial, orthomyxu, coronaviruses, etc., etc. There are many possibilities there. If we take a look at the variation by time, place, and person, we can easily see that there is no variation according to person, because there is universal susceptibility to common flu and to human influenza. Anyone can get you anytime. There is no variation according to place. The disease is, of course, pandemic in nature. It affects the whole globe, though because seasons are inverted, you will have different strains of human flu, for example, causing seasonal cold in the northern and the southern hemisphere during this same calendar year, and that's why different vaccines are used. Different vaccine cocktails. Because the flu shot is in fact a cocktail of 4 different viruses. So no variation here and no variation here, but there is certainly a variation over time with this disease. 1 to 3 peaks in general are possible, and that's dependent on geographic location. In general, in countries in the temperate climate zone, you have 2 annual peaks of the disease. So here we finally found some typical variation of this disease. And you must know the triad in general for all common diseases in medicine. Okay, one important concept, of course, of epidemiology is this thing called risk. Now, what's risk? Theoretically, technically speaking, from the point of view of mathematics and statistics, as a branch of mathematics, the risk is simply the probability of something happening. Though, colloquially speaking, when we say risk, we imply the probability of something negative happening, some adverse event. So in non-infectious epidemiology, we are trying to establish such risks, to calculate them. Like, for example, alcohol abuse raises the probability of the likelihood of developing liver cirrhosis 15 times, for example. Now that's a risk. We don't use this in the context of infectious diseases normally because, of course, a patient that has been in contact with Yersinia pestis, for example, will develop pest, or it will develop typhus in the case of Salmonella typhi or Rickettsia prowazekii. Of course, this infection is already a transmissive infection. The risk may be considered absolute there, 100%. You are exposed to the risk, you develop the disease. But in non-infectious epidemiology, being exposed, so in contact with the risk, the risk factor does not necessarily mean that you develop the disease. The risk is heightened. The probability, the likelihood that this will happen. And epidemiologic studies try to calculate this risk. Okay, let's skip this now. I would recommend that you read, by the way, all presentations once before the final exam. I think this would be enough. You need to know the basic concepts. We won't ask you of many particular details, and in general, state certification exams are easier than the semestrial exams you had during the previous years. Comparisons of groups in epidemiology. Now, this is important in the context of epidemiologic mass studies. The very basic idea of epidemiologic mass studies is to compare two or more groups that have different exposure to certain risk factors. So the idea, for example, is to compare a group that has been exposed to the risk factor, for example, tobacco smoking or alcohol drinking, with another group that did not have exposure to the risk factor, and then see whether disease frequency will be different in the two groups. And then, of course, judging by this, we can establish whether alcohol and tobacco are risk factors and should be addressed in the context of health policy. Let's skip this now. Inequalities in health, of course, this is studied also by demography, epidemiology, public health in general. This is not something that is foreseen in the context of purely clinical disciplines like infectious diseases, for example, because such clinical disciplines assume that all patients are the same. So if you have the infectious agent present or any other causative agent, the same disease will develop in the patient, but it doesn't work like this in real life. Of course, different groups in society, different strata of society have differential susceptibility to the disease. So inevitably, epidemiology also studies this, and there is a branch of epidemiology even called social epidemiology, which studies the distribution of such social factors among the general population, which predisposed to disease. Okay, let's go on. Let's skip this. Now, on the importance of epidemiologic studies. Here is an interesting example on how the spread of certain diseases, the appearance of certain epidemics is in fact entirely dependent on the societal context. So it's not enough to have an infectious agent, for example, that is very contagious and a susceptible population. Theoretically, you need to have an entire human society susceptible to this disease. So let's read this quickly as an example of how the size and structure of the population affects disease spread, which is again something studied by both medical demography and epidemiology. Now, imagine a world where humans live an isolated lifestyle, avoiding others whenever possible, using only technologies to communicate. And we've seen, by the way, examples of such a world already. There are many people already who like to live like this. And then we had the lockdown, the quarantine during the COVID-19 epidemic. So you have some idea already on how what such a world would look like. And it will probably happen one day with subsequent generations. Now, in this imaginary or not so imaginary already future world, which will soon be feasible, diseases which are transmitted from person to person would occur rarely. The causes of such diseases would not be able to propagate and would become extinct. So an isolated individual or small group would not develop diseases such as tuberculosis, leprosy, influenza, common cold, measles, mumps, AIDS, and sexually transmitted diseases. Smallpox would not have been the genocidal scourge it was, yes, when it existed, before it was eradicated. Some of the microorganisms causing these diseases are exclusively human pathogens, for example, the leprosy, bacillus, mumps, the mumps virus, the measles virus, so they would not survive, and they would rapidly become extinct. Assuming that humans also isolated themselves from animals, the zoonotic diseases, including Lyme's disease and brucellosis, would not occur. The human-animal cycle necessary for the propagation of parasitic diseases would be broken. The effect would not just be on highly contagious diseases. Ulcers associated with infection by Helicobacter pylori would be less common. Cancers linked to infection would not occur, or their incidence would be profoundly reduced. For example, cervical cancer, which is primarily caused by the human papillomavirus transmitted sexually, and gastric cancer, assuming the hypothesis that it is a consequence of chronic gastritis from the Helicobacter pylori infection. The health problems linked to passive smoking would also be avoided. Okay. Let's skip this now, though you have to read this before the exam. The concept of the so-called sick populations, where certain modes of behavior are considered normal in this particular society, so it would be more prone to a certain disease. And that's not surprising, by the way. Speaking of risk factors, like I already mentioned, you can broadly classify risk factors to non-communicable diseases as behavioral risk factors, metabolic risk factors, genetic and external risk factors. External meaning environmental and occupational risk factors. Most important of them would be the behavioral risk factors. And most major diseases in modern developed countries are caused by behavioral risk factors. So this is what patients do to harm themselves. Of course, if you compare a patient in an underdeveloped country living in an underdeveloped country, like some very poor African country, you will immediately notice that such a patient is a victim of circumstance. So he's living in a dangerous environment. But it's not like this for European patients, for example, or patients in North America or the Far East, so the highly developed countries. They don't live in risky environments. In fact, they have all of these diseases they have mostly because they have caused themselves, they have incurred themselves these diseases. If you see a patient with diabetes type 2 or metabolic syndrome, of course, this disease happened most probably because of behavioral risk factors. So certain individual risky behaviors. So our typical patients in highly developed countries are not victims. Certainly not innocent victims. So epidemiology would study, of course, the spread of all of these risky behaviors in a certain society predisposing to disease. Risk factors, causes, and associations. I already mentioned this, that association is not causation. You have to read this again before the exam. Some examples. Several hundred risk factors have been associated with coronary heart disease. That said, the following modifiable risk factors have been established as truly important. So, high levels of low and very low density lipoprotein, total serum cholesterol, total triglycerides, high blood pressure, smoking, hypodynamia, obesity, or overweight, pre-existing diabetes, type 1 or type 2, of course. Because I mean diabetes mellitus, not diabetes insipidus. Apparently, the task of epidemiology is to identify the risk factors for non-communicable diseases, establish the strength of association, and prioritize them. So, which of the risk factors should be addressed first? With communicable diseases, like I mentioned, the task is pretty simple. Epidemiologic studies measure, present, and interpret frequency of disease and of factors that influence the spread of disease. The epidemiological question is who gets the disease, in what quantity, and how does this compare with other populations? And these are called then absolute and relative measures of comparison. The epidemiological strategy for working out causes of diseases works best by using the comparative approach, while that for assessing a population's health needs works best by examining by using the absolute approach. While there are many measures to virtually underpin all epidemiology, incidence and prevalence rates. Now, to quickly remind you of this, if, for example, I tell you that we've registered 200 new cases of HIV/AIDS in Bulgaria in 2022, this is incidence. Basically, the ongoing registration of new cases, newly registered cases of disease. But if I tell you that we have a total of 4,000 cases of AIDS by the end of the year 2022, this is prevalence. And the very fact that incidence and prevalence are different here tells you that there is an effect of accumulation. This means that this is not your typical acute diseases that appears all of a sudden and then disappears all of a sudden. Because in the typical acute disease, in the course of 1 or 2 weeks, the patient will be cured, or the patient will die. Doesn't really matter, but the disease is over. But with chronic diseases, no, they don't disappear. So once the patient develops the disease, he will not die anytime soon. He may live for decades from now on, but he will have the disease for the rest of his life, because most chronic diseases that we have nowadays are incurable. So there is an effect of accumulation here. And prevalence is best used to measure such chronic diseases where cases accumulate among the population, while incidence is used to measure the occurrence of acute diseases where cases would appear and then disappear soon afterwards, like it will be with COVID-19, for example. In most cases, you won't see things such as long COVID or the post-COVID-19 syndrome. In fact, it will progress as an acute disease. The patient will be as good as new after 2 weeks, or the patient will be dead. Okay, and here you see some of the measures that are regularly used in epidemiology, regularly calculated as a result of epidemiologic studies. Some explanations here on incidence and what's the difference between incidence and cumulative incidence. We can leave this for later. You can read it at home. Basically, the cumulative incidence is a simple measure, because in cumulative incidence, you divide the number of newly discovered cases by the number of the population at risk, the population that can theoretically develop the disease. And if you don't know what's the size of the population at risk, you simply use the whole population there as a proxy. And the incidence rate is certainly more complicated. It's normally only calculated in the context of epidemiologic studies, because there in the denominator, this strange measure of person time appears. Normally it's person years, and it's the sum of the time spent at risk by members of the population at risk, which is complicated, but it's not so important. Just remember that incidence refers to new cases and is used in the context of acute diseases. Basically, the idea of incidence is to diagnose an epidemic. And that's why for certain infectious diseases, we even have some strict numeric criteria. So how many new cases of human flu should we have, or new cases of meningococcal type B infections to officially proclaim an epidemic in society. But prevalence is used for something completely different. The final accumulated number of cases, it is used basically for planning in healthcare. Because in the context of a chronic disease, you don't really care on the number of new cases, like in the case of diabetes type 2. Because the rate at which new cases appear, which is the incidence, is pretty small and pretty constant. After all, nothing has changed about the population. It's still the same population with the same risky habits year after year. So if 1 year you have 300 new cases, most probably in the next year you also have 300 new cases among the same population. But you're interested in the final count, the final number, because all of these people need treatment. So that's why prevalence is used for planning in healthcare. You need, of course, to know the final number of people with essential arterial hypertension or secondary arterial hypertension, and in what clinical stage they are, because you need certain stockpiles of whatever, calcium antagonists, beta blockers, ACE inhibitors to treat them. Okay. Let's skip this now. You can read it later. Prevalence, etc., etc. In the context of prevalence, you have two different types of prevalence. You have point prevalence and period prevalence. Period prevalence is the prevalence for a very long period of time. You have these explanations in the presentation, and point prevalence is the prevalence on a certain date or at a certain moment defined differently in time. And point prevalence is by definition measured on the basis of a certain population that has underwent actual examinations, tests, etc. While period prevalence refers normally to populations where routine medical statistics is collected coming from any sources. Okay, you can read this later. Has fixed and dynamic populations. Now, a fixed population or a fixed cohort is a group of people that is monitored in epidemiology, and it remains pretty constant. So not many people will die in this observed population. Not many new people will be added or emigrate from this population, etc., etc. If it's a dynamic population or dynamic cohort, then it means that large changes will be observed in the initial group. Now, there are some practical considerations here. So for fixed populations, for example, you can use the cumulative incidence, but it's not correct to use the cumulative incidence in a dynamic population. There you have to use the actual incidence rate. Okay, you can read this later. So the choice of incidence of or prevalence as a measure. As a general principle, for studies on the causes of disease, the incidence rate is preferred. For studies on the burden of disease, so how many people live with the condition and are adversely affected by it, for example, disabled by it, Incidence is also preferred. The prevalence is measures are preferred for long-term diseases. And for health behaviors and other risk factors, prevalence is also the preferred measures. Morbidity, mortality. Okay, let's skip this. Just to remind you that in general, in the context of epidemiology, when you simply count cases of disease, this is called morbidity. So, for example, how many cases of COVID-19 we had during the year? This is morbidity. Just cases, nothing more. And the two ways in which morbidity is measured are incidence and prevalence. Then you have a certain part of the population which did not die, but they never got back to normal. So their functioning is limited, they're disabled. This is what disability measures. For example, in the context of COVID-19, those with long COVID, post-COVID syndrome. In the context of strokes, for example, those with paralysis after that. And then you have a part of the diseased population that has died. And this is what the different measures of mortality measure. So we have morbidity, disability, mortality. Three different possible outcomes of disease, negative outcomes. Standardized mortality, okay, I mentioned this in the context of demography. Case fatality rate, that's a different type of mortality. Because if we measure mortality as a demographic indicator, I mentioned this yesterday, it's the number of people that have died divided by the whole population. But in the case fatality, it's the number of people that have died from a certain diagnosis divided by the people that have this diagnosis. So it's specific, disease-specific mortality, the case fatality. So for example, if it's 15%, it means that 15 out of each 100 persons with infarction or stroke died. And the rest recovered, more or less. This is what 15% case fatality rate would mean. Relative measures. Now, this is important in the context of epidemiologic studies. Here's a quick example, though I'll mention it in a few minutes when we take a look at the different study designs. So, a cohort of 1,000 regular football players and 1,000 non-footballers were followed to see if playing football was significant in the injuries they received. After 1 year of follow-up, there had been 12 broken legs in the football players and 4 in non-footballers. So, the risk of a footballer breaking a leg was therefore 12 divided by 1,000. The risk of a non-footballer was 4 divided by 1,000. So the risk ratio of breaking a leg was this divided by this, which is 3. Which means that footballers have a 3 times increased risk of breaking a leg. They're 3 times more likely to suffer from a broken leg than non-footballers. Okay. But then we run into some statistical considerations. As you can see, the 95% confidence interval is 0.97 to 9.41, which is not good because the confidence interval includes the value of 1. And the relative risk of 1 means that there is no difference. The risk factor is not a risk factor. So, in fact, these results may have been a statistical error, some statistical deviation. So, as a result of this study, Of course, you have to inform the public that our findings, for example, point to a 3 times increased risk, but more studies are necessary. That's what you should finish with if you get such inconclusive result. The odds ratio is an analog of the relative risk, mostly used in case control studies. Here's a quick example. A group of 100 patients with knee injuries, so-called cases in the case control study, was matched for age and sex to 100 patients who did not have injured knees to serve as controls. Now, in the group of cases, 40 skied and 60 did not, giving the odds of being a skier for this group of 0.66. In the controls, 20 patients skied, 80 did not. The odds of being a skier, 0.25. We can therefore calculate the odds ratio as being 2.64. But the 95% confidence interval here is way shorter. The smaller it is, the better. And it doesn't include the value of 1. So, apparently, this is not a chance finding. We can be absolutely certain then that we have established a risk factor here. So the odds ratio of 2.64 means that the number of skiers in the case is higher than the number of skiers, so almost 3 times increased probability to damage your knee if you ski, and the result is here statistically significant. So it's a dangerous sport. We can be certain about this now. Okay, what's the point? The epidemiological idea is a simple one. If a disease is causally associated with an exposure, then the odds of exposure in the diseased group will be higher than the corresponding odds in the non-diseased group. If there is no association, the odds ratio will be 1. If the exposure is protective against the disease, the odds ratio will be less than 1 because you can discover a protective factor, not necessarily a risk factor. For a cohort study, the corresponding idea is that if an exposure is associated with the disease, then the odds of disease in the exposed group will be higher than in the non-exposed group. Example, the risk of developing lung cancer in heavy smokers is almost 25 times higher than the risk for non-smokers. And then you have some additional measures of absolute comparison. You can read them at home. Let's skip this now. And let's take a quick look now at the different types of epidemiological studies. How do you make these comparisons in epidemiology? So let's start with the observational studies and with the descriptive studies. So here's the hierarchy of proof, of evidence in medicine in general. So, for example, we wonder, is this substance carcinogenic? We've just found it, for example, in plastic bottles used to drink water. Does this mean everyone that drinks water from plastic bottles will get cancer? Or we wonder, is this new drug or vaccine effective, etc., etc.? What is the hierarchy of evidence? What can we rely upon? So at the very bottom, you have in vitro research, which means that all of these wonderful things that you studied when you studied biochemistry, genetics, etc., are virtually useless. Very rarely, sciences such as genetics can come up with anything remotely useful to actual medicine. In 9 out of 10 cases, or 99 out of 100 cases, their new discovery turns out to be complete trash. It's worthless. Because just because you've established some effect that appears to be valid on isolated cells and even tissue cultures doesn't mean that this effect will be present in the actual vertebrate organism with its near perfect immune system. In most cases, it will not be present. It will turn out that just because this gene or whatever predisposes to this disease, it doesn't have this effect in actual real life. Just because this drug or vaccine was found to work against cancer cells, whatever, in vitro, doesn't mean that it will work in actual life and you can administer it as drugs to patients. No, you just waste your time. So, next step, animal research. A little higher. Then, ideas, opinions, editorials. So, this is the clinical experience of individual doctors. And then we enter the realm of epidemiology, where we finally gain some trustworthy evidence. Because all of these hypotheses generated by laboratory sciences and individual opinions have to be tried and tested in experiments over very large groups of people over many, many years, until we finally find out whether this effect actually exists. And this is the hierarchy in general. At the very bottom here, we have clinical studies with no control groups. So this is what's routinely done in clinical wards. Then you have the epidemiological studies that are purely descriptive in nature. Then you have analytical studies, which allow us to calculate risks. And finally, we have experimental and intervention studies like the clinical trials. And this is the best evidence we can have. And these here are, in fact, summaries of the results of many clinical trials. In the end, this is what we rely on when we prepare clinical recommendations, guidelines to use when we diagnose and treat our patients. We rely on such findings. We don't care about these things. These are just, cheap sensations for the masses. Like scientists from whatever university, hospital just discovered a new promising treatment for cancer, blah, 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 etc. Nothing to do, of course, with real life. Okay, so what's the general scheme, the general overview of epidemiologic studies? This thing here called case reports or case series means that you follow a group of patients. For example, you study a group of 15 patients with COVID-19 hospitalized in the ward, whatever ward in our hospital. There is no control group here, and this is a case series study. What is it used for? Well, the case series study is used to study the natural history of a disease. It is used to establish all the possible symptoms, the constellation of symptoms in a disease and clinical science as well. Like, for example, on the basis of such studies, you can say that, yes, okay, with the Delta strains of the SARS-CoV-2 virus, let's say 10% of all patients will exhibit anosmia. 1% of all patients infected will exhibit the Dick syndrome, disseminated intravascular coagulation, etc., etc., so on and so forth. Then you progress to oncologic and cross-sectional studies, where you already use control groups, but these are all up to this point called descriptive studies. They're used to generate hypotheses. So on the basis of such studies, you can say that, okay, it seems that tobacco smoking probably causes lung cancer, but that's just a hypothesis. You have to test it with analytic studies and whenever possible by experimental studies. So you progress to the analytical studies where you calculate actual risks, and here you have two types of analytic studies. And finally, you have the three types of experimental or intervention studies. Field trials, community trials, and randomized controlled trials or clinical trials. You perform them whenever possible. They are subject to extra ethical constraints, so they're not always possible. If it's impossible to organize an experimental or intervention study, you rely instead on the results from analytic studies. Okay, so these are some alternative names for the studies. This is the unit of study. In such designs, you can check this later. Now, understand that understanding disease causation and measuring the burden of disease are the two key purposes underlying epidemiologic studies. All study designs potentially contribute to questions of cause and effect, health policy and planning, and clinical practice. A clinical case series is a coherent set of cases compiled by one or few clinicians. A population case series study consisting of a set of cases in a defined population and time lays the foundation for description of the disease by place, time, and features of the population, so the epidemiologic triad. If cases are compared with non-cases from the same population, the design is that of a case control study, which generates and tests causal hypotheses. A cross-sectional study measures disease and risk factor prevalence in a sample of individuals in a defined time period, mainly to explore the burden of disease, but also to generate associations. The burden of disease is how many people are affected among the general population, how many of them are disabled, how many have died prematurely, etc., etc., but also to generate associations. A cohort study consists of a sample of individuals in the population followed up over time to observe changes in health status, to measure disease and incidence, and to examine associations. I'll provide examples. The clinical trial is similar in design to a cohort study, except that the investigators impose an intervention on one or more of the study populations. The ecological design is a mode of analysis based on variables being studied in relation to places rather than individuals. So, case series study. Limited descriptive information in which the characteristics of several patients with a specific disease are described, but are not compared with those of a reference population. It often stimulates the initiation of a more detailed epidemiological study. And here you have an example. So sometimes, yes, they can generate even an etiology hypothesis. Because, as you can see here, the AIDS was not known initially as a disease per se. Initially, they simply observed that many cases seem to appear of diseases that are considered extremely rare. Like, for example, in 1981, they described a series of such 4 young patients with a very rare form of pneumonia. It was, in fact, the pneumonia caused by Pneumocystis carinii. Pneumocystis carinii, which is almost impossible to observe in any patient. He must have some extremely severe immunodeficiency, be left with virtually no immunity to develop such a rare form of pneumonia. Or they observed cases with Kaposi's sarcoma. And then, judging by that, they said that okay, maybe we have some underlying disease. We have some new disease causing extreme immunodeficiency. The CD4 plus fractions of the T lymphocytes are non-existent already. Something has depleted them, and now as a consequence we observe all of these rare opportunistic infections, and they started searching for the underlying cause, some new disease that appeared out of nowhere. And it was, of course, the HIV-1 and HIV-2 viruses already being spread initially among the male gay community of San Francisco, later among the drug addicts. Observational studies. So all of these here are called observational studies because the investigator does not intervene in any way into the natural cause of events. He just observes. So these are all observational, the descriptive and the analytic studies, but these are intervention studies, the experimental ones. Observational studies allow nature to take its course. They include studies that can be called descriptive or analytical. A descriptive study is limited to a description of the occurrence of a disease in a population. It's often the first step in an epidemiological investigation. To a large extent, descriptive studies coincide with the normal routine health statistics that is anyway gathered in all developed countries. You just need to know what to do with it. The analytical study goes further by analyzing relationships between health status and other variables. Experimental studies, they involve an active attempt to change a disease determinant, such as an exposure or a behavior, or the progress of a disease through treatment. They are subject to extra constraints, since the health of participants may be at stake. Major experimental study designs include the following: randomized, controlled trials, field trials, community trials. I mentioned this already. Okay. Descriptive study. They represent a simple description of the health status of a community based on routinely available data or on data obtained in special surveys. They are often the first step in an epidemiological investigation. In many countries, this type of study is undertaken by a National Center of Health Statistics. Pure descriptive studies make no attempt to analyze the links between exposure and effect. They are usually based on mortality statistics and may examine patterns of death by age, sex, or ethnicity during specified time periods or in various countries. A classic example of descriptive data which charts the patterns of maternal mortality in Sweden since the middle of the 18th century, showing maternal death rates per 100,000 live births. And then, okay, you can read this yourself later, or the study on the child mortality in the UK. Here you have some illustrations on the time trends here. The next step in investigation. You can read these things yourselves, and you have an example of such a study related to the heat wave in France. And yes, okay, then the ecological fallacy. Okay, I'll skip this now. I'll leave this to you. I'll just provide a very quick explanation here. A very quick and elementary explanation. So, I already told you what's the case series study. What's then the ecologic or correlational study? It involves group level comparison. So, for example, you take the whole population of Bulgaria and the whole population of Switzerland. You're interested in some possible association there. So for example, you say, like in this very, very simple example, one of the first associations studied in non-infectious epidemiology, you clearly observe that there are more smokers among the Bulgarian population in all possible age groups, right? Right. So you can, of course, hypothesize here that since you have more smokers in all possible age groups of the Bulgarian population, this means that this is probably why you have more cases of lung cancer in Bulgaria than in Switzerland. But you're not sure yet. Anyway, that's an ecological study. You compare whole groups of people. In this group, you have more of this risk factor. Probably that's why we have more cases of the disease in this group. The cross-sectional study or transverse study is a little more accurate because here you've identified all the participants individually. Other than that, it's the simple enumeration of cases of a disease and cases of possibly related risk factors on a certain territory at a certain moment in time, again used to generate a hypothesis. So, for example, in the northwestern region of Bulgaria, we found 100,000, let's say, patients with essential arterial hypertension. We found 60,000 with high salt intake in the diet, 30,000 severely stressed on their workplace, 40,000 with low physical activity, 80,000 with some poor diet, a lot of simple sugars in the diet, etc., etc. 40,000 that are overweight, 10,000 that are clinically obese, etc., etc. And then you suspect that all of these risk factors present are somehow associated with the disease present, but again, it's just a hypothesis yet. So, how do you test these hypotheses that you obtain from all of these types of studies here, mostly the ecologic and the cross-sectional study? You have to progress to these two types of analytical studies. We'll take a look at them in the next presentation, but let me provide some very quick and elementary explanations here again. And you can always, of course, study the presentation yourself. What's a cohort study? A cohort is a term that stands for uniform group in epidemiology. Why do we use uniform groups in epidemiology? Because we strongly suspect that the susceptibility to the disease is different in different groups of the population. And it's true, by the way. For example, smoking is way more dangerous. People are way more susceptible to it if they are young. So smoking is way more dangerous for a 15-year-old than it is for a 35-year-old. Also, smoking is way more dangerous for a woman than a man. Susceptibility is much higher to lung cancer, laryngeal cancer, etc., etc. So it's not that it's a very clever thing for, let's say, a 20, 30, 40-year-old man to smoke. No, but for a woman to smoke, it's doubly stupid because, of course, she's way more susceptible to the effects of tobacco smoking. And it's not, of course, just the lungs of the woman that are weaker. Also, the liver is weaker, so she'll be more susceptible to the effects of alcohol. So you can find the same relation in other places. Now, it's true that the heart of a woman seems to be more resilient to adverse effects from the environment. That's true in most risk factors, but for the lungs and livers, it's just the opposite. But we have to study them separately, because at the same level of exposure to the risk factor, a very different number of cases of disease will develop in the two groups. So you have to choose. In your cohort, you must include either 20-year-old men or 40-year-old women or whatever, but you have to form a uniform group. So you have your cohort, your more or less uniform group, and then you subdivide it into two or more subgroups. Normally it's two groups. One group is exposed to the risk factor studied, and the other group is not exposed. Like, for example, you have a group of smokers and you compare them with a group of non-smokers. Then you follow them up, so you observe the group for many, many years, registering what's happening with them. And in the end, after many years, you stop the study and you start counting the cases of disease in one group and the other. That's a cohort study. And if your initial assumption was true, if your hypothesis was true that tobacco smoking causes lung cancer, you will find more cases of lung cancer in the group of smokers. If this doesn't happen, that your assumption has failed. In fact, tobacco smoking is harmless then, and you should just leave people alone. Why deprive them of their favorite habit if smoking is harmless? But you have to establish this after years of study on thousands of people. That's the only way to do it. You can test this association between smoking and cancer in another way. You can use the case control design. So this study looks like a mirror image of this study. So you don't move from the cause to the effect, from the exposure to the disease, like it is in a cohort study. You move backwards. You take a group of cases. So these are people who already have lung cancer, and you compare them with a group of controls that are more or less similar. So again, same age, same sex, but they don't have cancer of any type, not just lung cancer. They may have other diseases, though. That's completely acceptable here. And then you go back in time. Not literally, because travels in time are not possible, at least yet. But you interview them, you interview people who have serviced them, who know them. You study their medical documentation, and you try to find out how much they have smoked in the past. That's a case control study. So by nature, this is a prospective study, moving ahead in time, and this goes backwards. It's a retrospective study. So in the case control study, you're trying to find out, to establish how much they were exposed to the risk factor in the past. So that's the general logic of all of these studies. And again, if you find more smokers in the group that currently has cancer, the group of cases, you have proven the hypothesis. And you can calculate the risk successfully. If not, then people can smoke all they like, of course. Doesn't really matter. So the presentation on analytical studies, you can read this at home. Just a quick walk here. I've kept this presentation short. The case control study is a comparative study where people with the disease are compared with people without the disease. The cases can be obtained from a number of sources. The cases are compared with controls. Information is obtained on the social and medical history of cases and controls, as the causal factors have already had their effect in causing disease in the case group, and the information required is recalled from the past. The case control study is sometimes referred as a retrospective study. Apparently, that's the general scheme of it. You have the group of cases, the group of controls, and then you calculate how many exposed individuals, so in contact with the risk factor, you had for the last years in the group of cases and in the group of controls. That's it. Matching in case control studies, again, like in the cohort study, you should choose people that are as similar as possible, because the effects of the risk factors will be felt differently in different groups of the population. Cohort study. The word cohort is derived from the Latin term cohors. In Roman times, it was a separate part of the Roman legion, normally around 400 men. In epidemiological terms, the cohort is a group of people with something in common. The cohort study involves tracking the study population over a period of time. So it's called also a follow-up, a longitudinal, or a prospective study. The hallmark of this design is that health outcome or health change data are obtained on the same individuals in a population at more than one time. The idea here is also sometimes to study not just the association, but the natural history of a disease, like similarly to the case series. Here's a general scheme. We have the study participant, the initial cohort, then based on whether the risk factor is present, you divide them into the group of exposed individuals, the group of not exposed individuals, and then you measure the final outcome, which may be new cases of disease, cases of disability, fatal cases, whatever it is, some clinical outcome you have to measure. And if you find more cases of the outcome in the exposed group, you've proven the association. You begin the study here, you end it here after many years. Cohort studies functions, okay, you can read this later. And the final presentation, let's take a look at it quickly, and then I'll upload all of them. I've already uploaded the practical task, the assignment to the classroom, and we're finished for today. Intervention studies. Epidemiological studies can be classified as either observational or experimental. And among the observational, we have descriptive and analytical. So we've seen this already, and we've seen this. Experimental studies involve an active attempt to change a disease determinant, such as an exposure or a behavior. So why is the cohort study, by the way, not an experimental study? Because when you study a group of smokers in relation to a group of non-smokers, you did not do what is ethically forbidden. For example, it may really be important for you to know what are the effects of smoking, but you are not allowed as an investigator to put conscientiously the health of the participants at risk. It's mentioned here. You cannot do that. So, for example, you cannot persuade half of the cohort to start smoking just because you would like to see what the effects will be. For example, you persuade them to start smoking because, yes, most probably they'll develop some nasty diseases, but it's okay. Even if they die, it will be for the good of the whole humankind. You're not allowed to persuade them to do this. Next, you're not allowed, if they're prisoners of war, for example, you participate in the war between Russia and Ukraine, to simply command them to start smoking 2 or 3 packs of cigarettes per day because you would like to establish the effects. You're a military doctor and you have test subjects here like guinea pigs. No, you're not allowed to do this. You're not even allowed to pay them to start smoking. You can't tell the participants, I'll pay you €500 per month if you smoke 1 pack of cigarettes per day. I would really like to know what the effects are. But if you agree to smoke 3 packs of cigarettes per day, I will now pay you €2,000 per month. Again, this is completely out of the question in modern medicine. So you have to pick people who already smoke on their own volition. You did not make them to do it. So it's not considered an experimental, an intervention study. So experimental or intervention studies are possible only when the effects are beneficial. You are allowed, of course, to test a new vaccine or drug, but you are not allowed to test some risk factors. For example, you're not allowed to simply infect the population of the city with the hepatitis B or the hepatitis C virus just because you would like to know which of the two raises more the probability of liver carcinoma developing. Okay, let's proceed now. The intervention or experimentation involves attempting to change a variable in one or more groups of people. These are, of course, these represent the best possible type of study. Whenever possible, we should have experimental studies in medicine. This could mean the elimination of a dietary factor thought to cause allergy, or testing a new treatment on a selected group of patients. The effects of an intervention are, of course, measured by comparing the outcome in the experimental group with that in the control group. So it looks a lot like the cohort study. It's just that you deliberately, conscientiously subjected to the factor studied the experimental group. While in the cohort study, this was not deliberate. That's the only difference. Since the interventions are strictly determined by the study protocol, ethical considerations are of paramount importance. No patient should be denied appropriate treatment as a result of his participation in the experiment. And the treatment tested must be acceptable in the light of current knowledge. Informed consent from study participants is required in all circumstances. This is the general scheme of clinical trials. You have the study population, you take participants out of it, then you randomly assign them to an experimental group and the control group where no for example, new drug is administered, and then you compare the outcome in terms of cases of disease, presence of symptoms, the fatality rate, whatever, and the investigator, of course, then reads the results, so to speak. A randomized controlled trial is an epidemiological experiment designed to study the effects of a particular intervention, usually a treatment for a specific disease. Randomization is important. Okay, how to randomize. Okay, let's keep this. Let's keep this. Let me explain this instead, and we're almost finished. So these are the keywords here. A well-organized clinical trial must tick all the boxes here. It should be multi-center, randomized, placebo-controlled, and double-blind. Now, if you studied clinical pharmacology or something like this, you should know these things already. What do they mean? Just to remind you quickly. A multi-center clinical trial means that you organize a trial in several hospitals at once, and the results are treated by several laboratories at once, clinical laboratories, imaging diagnostics, whatever, to eliminate subjectivity. Then the study should be randomized. What does this mean? You randomly choose participants for the intervention group and for the control group, and then you randomly assign participants to the group that receives the new drug, for example, and the placebo group, which doesn't receive anything but is deceived that they receive a drug. So you have two randomizations here. Why? Because the first randomization is performed because if you have a truly random sample of the population, the studied participants will be representative of the whole population. So it is very likely that you will have, for example, the same percentage of women, of elderly people, of people of higher education, etc., as in the general population. Because if you don't do this, if you don't randomize, and you simply wait for volunteers to appear in your study, most probably they'll be different from the mainstream population, so results will not be valid for the whole population. If you have young participants in the study, they will have, for example, very different compliance therapeutic discipline in comparison to the elderly patients for which the treatment was meant anyway. So it's very important that the studied group corresponds to the group that will use the results of the study in the future. And then as for the randomization here, if you're testing some new and potentially dangerous drug, vaccine, whatever, and you know as a doctor who receives what, of course, you give the placebo to people you like and you give the drug to people you don't like. For example, some members of the Roma minority, some refugees, illegal migrants are included there. Okay, you give them the dangerous drug. No, this should not be done. This should not be allowed. So you need to have randomization here and blinding, as we'll see in a minute. Or if you know that the drug is completely safe, and the aim of the trial is in fact just to find the dosage necessary, because a well-known drug will be output in a new tablet form, for example, then you can assign the drug. Or if it's something new, innovative therapy, you have patients that have lost hope, you give the drug to them. And those that are not in such dire need, you give them the placebo. Again, this is not allowed. So two randomizations, then it's placebo-controlled. There was a time in medicine, particularly up until the 70s of the 20th century, when new drugs were tested against old drugs. For example, you test the efficacy of an antibiotic in a certain type of pneumonia, for example, interstitial pneumonia. Then you would compare a macrolide with the cephalosporin third generation or something else. That's not done anymore. Now we compare drugs or whatever it is with placebo. So half the group, the control group, will receive nothing. They'll be conscientiously deceived. They receive more or less the same pill, same shape, same color, same taste, but there's nothing in it, just sugar and water. So why do we do this? Because the hypnotic effect is always present. The placebo effect is always present. The patient deceiving himself that he has felt some beneficiary or some adverse effects from the drug being administered. So the aim of the modern clinical trial is not so much to establish whether the drug works. It always works in some way or another. The aim of the modern clinical trial is to find out whether the new drug surpasses the placebo effect, and does it surpass it by much? If it doesn't, this new drug is good for nothing. It shouldn't be registered. Okay, so placebo controlled. And finally, double blind. What does this mean? In the past, they organized single blind trials, which means that the patients don't know what they receive, but the doctors and nurses in the ward know what they give them. Nowadays, we have double blind studies, which means what? Doctors and nurses don't know what they give them. Who knows what the patients receive? The monitor of the clinical trial, which is a doctor in most cases working directly for the pharmaceutical company or the company for clinical trials. And nowadays, we even have triple blind studies, though they are not routinely used, at least yet, when even the monitor does not know. So only the headquarters of the company know who receives what. Okay, so strengths. I think they're pretty obvious. Experimental studies are the best way to establish causal relationship of any type. You can be absolutely certain here. If you have run such an experimental study. You can read this at home. Weaknesses, okay. Field trials, okay. So what's the difference of the other two types of studies? The difference is in community trials, you compare communities of people, entire communities, like different neighborhoods in the city. And in field trials, you test the new drug, vaccine, or whatever in the natural environment where people live and work. You do not walk them in some clinical ward in the hospital. So, for example, vaccines are tested through field trials. As for community trials, they are normally undertaken for studying interventions in the context of health promotion. For example, you compare a neighborhood where they tested in the same city, where they tested the effects of changed diet on the development of coronary heart disease, with another neighborhood where they instead opted for not for changing the diet, but raising the physical activity of the population. So they would like to see what is the better course of action, what is more strongly associated with the disease. That's a community trial. Okay, you'll see some examples here as well. And some schemes, generally explaining things. This is personalized medicine, personalized prescriptions nowadays. These are the different stages of clinical trials. Pay attention here that phase 4 continues indefinitely. So basically, you may safely state that all drugs, vaccines, etc., are experimental. They always involve experimentation. Some important, of course, ethical considerations. You need informed consent, confidentiality, respect for human rights, and scientific integrity in the context of experimental studies. So any participant can withdraw at any time. They are always complete volunteers, the participants in experimental studies. Anything that's learned about the participants should not be disclosed publicly. So confidentiality is crucial. Respect for individual rights. You have some peculiar examples here, like in Cuba, for example. You can see that they don't have this. They have the free testing for HIV/AIDS, but it's not anonymous, and that's because they consider these people public health threat. And in general, of course, no discrimination of participants in any sort of epidemiological study is allowed nowadays, because it wasn't like that in the past. You probably remember the old and famous Tuskegee experiment on the treatment of syphilis, where Afro-Americans were treated completely differently in comparison to the white population included in the trials in these several states. Scientific integrity, unfortunately. We have many examples of falsified studies, fabricated data, etc., etc. Nowadays, there are famous examples like this. Many famous examples, like Andrew Wakefield, who tried together with two other London surgeons to prove that vaccines cause autism and gastrointestinal syndrome similar to Crohn's disease in children. In fact, the blamed vaccine there was the MMR, the measles, mumps, rubella wild vaccine. The whole study was falsified, fabricated. They were paid to do so. So unfortunately, even doctors can turn to criminals when they have the incentive to do so. Then you have the example of these South African associated professors like me, who invented, so to speak, a new type of treatment for breast cancer, which was completely made up. And so for something like 2 or 3 years, they were like rock stars in medicine. And then it turned out that all of their clinical study was completely fabricated. And of course, they were expelled from the medical university. Okay, so This is it in general. Make sure to read the 4 presentations on epidemiology once, and then try to work on the epidemiology task, because immediately you'll see whether you properly understand things. Do you want me to upload again an additional textbook on epidemiology, or the presentations will be enough?
Hey, you tell us, Professor.
In the second course, we used the basic epidemiology, which is a very short Danish textbook of the Regional Office for Europe of the WHO. Okay, I may upload it, and then if you like, you may read at least again the first 3 chapters of it, if you have the time and the inclination to do so. But I think the presentations will be enough. So, okay, so it's your call.
Okay.
Doctor, so we
Yes.
don't need this book that you suggest in the end of the syllabus, which
No.
is called Social Medicine from Dr. Mutafova, right?
No, you don't need it. The material from presentations is meant to be completely enough for the state exam. Read all the presentations once.
And for the exercise you mentioned in the beginning?
It's uploaded already.
Okay.
Mhm.
Thank you.
Do the task, and then you immediately know whether you already understand all that you need to understand in epidemiology for the exam.
Okay.
All right. Yes?
No, thank you very much. And
Okay. So, see you tomorrow. Then, tomorrow we need to have, what's that? Morbidity and major diseases. So, in fact, the epidemiological situation.
okay. See you tomorrow.
See you tomorrow. Bye. Bye.
Bye.
Bye.